we have to pay bills like the radio does. And with that, we have with us today PPS. They're just going to do a short, very short presentation. You guys can come through.
Good afternoon, ladies and gentlemen. I know it's been quite a very long day and very informative and exciting for you guys, so I will really not take much of your time. I know you're tired by now. So, to introduce myself, my name is Nentlantla and I'm here as a PPS representative. PPS stands for Professional Provident Society. We're an insurance company which has been in operation for the past 81 years. What makes us different is that we are an insurance company that caters exclusively to professional graduates. And also what makes PPS very unique and interesting is that our company does not have shareholders. So we have clients in our company that become members, and our members are the one that benefits in the company in the form of shareholders, meaning that all the profits that is made by the company actually goes back to our clients, which are members. So this is how premiums are separated at PPS. A portion goes to claims, a portion goes to business operating expenses, a portion goes to reserves to make sure that our future claims are also paid on time, and then our profits goes back to our members and some are reinvested. Because we do not have shareholders, as I've stated, all our profit that the company actually makes goes back to our clients, which are members. And why do we do this? Because our aim is to actually protect our members, grow our members' income, and also create wealth for our members. And this is the power of our profit share account. Our profit share account is actually an account where all the profits that the company makes is put for each and every individual member. So what I mean by this is that being a PPS client or member means that you're automatically going to earn a bit of profits. By that, we create a share profit account for each and every member. And then what you could use the money for, of course, is to supplement your retirement savings. Say at retirement age, you do not have savings for retirement, such as a retirement annuity. You can use this money to supplement your retirement savings. You could also use it for ad hoc expenses such as holidays or to purchase assets or pay off assets. Pay off monthly expenses such as medical aid and so on. The power of this account as well, our profit share account, is that there's actually no premium. Every member at PPS is actually entitled to a share of profits. 100% of our profits and losses are distributed amongst members. Our profit share account is vested, meaning that when we put into your personal profit share account, that money is reinvested for you and it is administrated by PPS Investments. And then there are no penalties. By this, I mean that if you are to claim from your policies, it does not mean it will affect your profit share account. Your profit share account will be not affected anyhow by your claims. So this is how we actually calculate the amount of portion that is supposed to be put on your individual profit share account. Say you have 2 or more products with PPS, you get 5%. 3 or more products with PPS, you'll be getting 12.5%. 3 or more, you'll be getting 7.5%. So by this, we encourage our members to actually have more products with PPS. By more products, I mean having your life cover with PPS, your investment with PPS, say your car insurance with PPS, your medical aid, because by doing this, it means you benefit more from the share profits. Instead of a person says who has only 2 products with PPS, you'll be earning more on your profit share account. So I'll tell you a bit more about our main benefits that we offer at PPS. Firstly, as we know that our income is our greatest assets, PPS covers 100% of your income, both now and in future. PPS also covers 100% of your business expenses. It's for people who run their own practices, that's where they come in as well. Why would you need a sickness cover? For obvious reasons. Just because you're sick, it does not mean you don't need to pay your mortgage bond. It does not mean you don't have to pay for food, insurance, car and savings, and so on. all our monthly expenses remain in place, regardless of us being sick or not. I'm going to pass on this because I've already mentioned it. And our life cover. Our life, according to me, is our most valuable assets. And with our life cover, which is a standalone benefit, it pays out in the unfortunate event of you passing on to a nominated beneficiary or your estate. For obvious reasons, we all need life cover because no one wants to leave expenses or debts for their loved ones, and most of us would love to leave a legacy. So for life cover, would pay for your funeral, will cover your funeral expenses, you'd pay your debts off, educational expenses, replace loss of income, pay ongoing expenses as well. Some of the benefits that come with our life cover is PPS pays up to 50,000 within 48 hours to your family to cover for your medical expenses. Should you contact terminal illness, with terminal illness I mean you contacting any disease such as cancer, we will pay you 50% of your life cover to ensure that you seek the medical treatment that you need. And then we go to our critical illness cover. And the question here is, can you afford the cost associated with illness? PPS critical illness cover pays out should you or your child suffer any trauma or physical impairment. So why would you need a critical illness cover is that it helps you take time off. Say your child suffered cancer and you might actually want to also actually take time off as well, work to look after them. You might want to seek alternative treatment options, pay off additional expenses that are not covered by your medical aid. An amazing benefit of our critical illness cover is that your child is covered from day 1 until the age of 21. And then now, lastly, is our disability cover. And the question here is, can you afford the cost associated with being disabled? The PPS disability cover is a standalone benefit that pays out should you not be able to carry on your professional duties, that is performing your job, or you become functional disabled, meaning you cannot do our day-to-day operations such as eating, walking, dressing yourself, and so on. So why would one need disability cover? To make lifestyle adaptations, of course, to your home or work, take time out, pay off debts and additional medical expenses. So in closing, as I said, I would be short. I would like you to remember PPS for 4 things. We are exclusively available to graduate professionals. We cover across the globe, and our profit share account, and also no aggregation, meaning that your information is safe and secured with PPS. So if you ever need questions or assistance or to just check anything with regards to PPS, you can feel free to contact me. Those are my details, and thank you so much for your time. Oh, sorry, we're actually required to pass the attendant register, and PPS will not contact you if you do not want to be contacted. It is just an attendant register. Thank you so much. For any questions, I'll be outside.
Good afternoon, ladies and gentlemen. It has been my pleasure and privilege to be here with you today and meet and talk with some of you. Dental Protection is a division of Medical Protection Society. We have been exclusively looking after the medical and dental profession for 130 years internationally and 65 years in South Africa. It's all we do, it's all we know, and we know it back to front. I'm sure there are often quite a few questions, but seeing as this is a state and private sector thing here today, just by show of hands, if you work in the state sector, and how many of you think that if you're in the state sector, you don't need indemnity? Okay, so the truth of the matter is, unfortunately, we have a whole lot of seniors who are telling a whole lot of juniors that if you work in state, you don't need any extra indemnity. And the slight problem with that is that it is only a half-truth. So the state is responsible for covering claims in negligence or injury, which means that if there is compensation that needs to be paid to the patient or to their family, then the state will take care of it. However, as you would have seen from some cases that hit the newspapers a couple of years ago, if you are in state, you are not immune from HPCSA complaints or from, heaven forbid, criminal investigations. But the sad fact is that if an HPCSA complaint ever lands against you, the state will not assist you. And we're looking at about 250,000 Rand to get an HPCSA complaint resolved. If it ever comes down to criminal charges, and it's not just culpable homicide and murder that can land you with a criminal charge, then you're on your own again. And that, we're looking, recent figures that I heard, 50,000 Rand a day for high court time. So if you are a dental protection member, all you need to pay is your monthly subscription, and we take care of the 250,000 Rand and the 50,000 Rand a day. So if you are in the state sector, I would urge you to reconsider your position if you are not a dental protection member or if you don't have any other indemnity. I would, of course, love you to be with dental protection. But if you don't, please do something about it. I know it's the grudge expense and the grudge purchase, but please do something about that. I am around. I will have cards as well on the table outside, but if anybody has any questions, you're more than welcome to contact me. Thank you.
It's time now for the second round of the panel discussion. Slightly different, but although you can view it as a continuation of the discussions that we had in the morning. The subject of this panel discussion is the district health model. We want to look at the leadership, we want to look at structure and clinical services for effective oral health care. Right, so so in our panel today, again, we still have Dr. Mnuba, whom we introduced earlier on as the manager, oral health services at the National Department of Health. We have Dr. Sanele Poswa, she's clinical manager, oral health services, Gauteng Department of Health. We've got Dr. Avir Ramdao. Dr. Ramdao is secretary of the Public Oral Health Forum. I will ask him to say a little bit more about the Public Oral Health Forum when we start the discussion. And then we've got Dr. Jimmy Mtetwa. He spoke earlier on to welcoming you, and he's the CEO of this magnificent hospital, previously a dentist. But the reason why he's actually here is that for a very long time he was the manager of oral health services in KZN. So he actually knows a whole lot more on issues pertaining to oral health, especially pertaining to leadership, structure, and so on. Okay, so yes, we can start. Maybe Dr. Ramdao, would you like to say something about the Public Oral Health Forum, just by way of introduction? You can sit down.
Good afternoon, colleagues. So the Public Oral Health Forum was an organization that was formed by dental professionals in the public service. And we're an organization that represents dentists, dental assistants, dental therapists, oral hygienists. So we try to encompass every profession and make sure that they're all well represented. We advocate for the improvement of services in the public sector. We advocate for the improvement of services to the communities. Membership is free to the Public Oral Health Forum, and you can find us on social media. You can find our details, and membership applications and stuff are all available on Facebook and through Twitter as well, and LinkedIn. So
Sure.
that's just a little bit of the Public Oral Health Forum.
Yeah, so I'm quite comfortable for him to talk about Public Oral Health Forum because he assured me that it is not in competition with the DPA. Okay. Okay, let's get on to the topic, which is district health model, leadership structure, and clinical services for effective oral health care. Now, before we came here, I had circulated questions to the panelists, and this is a structure that we will follow so that we can effectively dispense with this particular subject. Now, the first issue to the panelists is what is the ideal structure and location of oral health within the districts, right? Because as we all know, delivery of oral health services takes place in the districts. Dr. Mkuba went to some length to explain, the difference between, what the national department does, what provincial departments do, and what is supposed to happen. So at an operational level, that's where services are delivered, and it happens at levels of districts. However, maybe just to be inclusive, Dr. Mkuba, because you are from national, and I don't want to exclude you from this discussion. Your office, how is it located? Maybe just by way of information, how is it located within the structure of the Department of Health at the national level, so that we can identify exactly the positioning of oral health, within the structure and hierarchy at the Department of Health.
Okay. First of all, the National Department of Health, administratively, you've got a Director General. That's the accounting officer of the department. Then under the Director General, you've got a number of professionals called Deputy Director Generals. Now, at National Department of Health, we call the group of programs they are leading, it's a branch. For instance, you have now a Deputy Director General that will deal with corporate governance, that will be legal, human resources, finances. And then you'll have a Deputy Director General that deals with health programs like HIV, oral health, and all that. So from those branches where it's a group of corporate services, human resources, and all that. So you call them Deputy Director General. Then under Deputy Director Generals, you've got what you call clusters or chief directorates. Now, each directorate will have a number of directors, directorates. For instance, we fall under a non-communicable chief directorate. Non-communicable branch or primary healthcare branch. That is a DDG, primary healthcare branch. That's where the line function is. But under that primary healthcare branch, there'll be 5 other chief directorate or clusters. Oral health will fall under the cluster of health promotion, nutrition, and oral health. That's a cluster. because there are 3 directorates. So we are reporting to this chief directorate, and then there will be oral health directorate and sub-directorate. So in the National Department of Health, oral health reports as a directorate to a chief directorate or cluster that is called Health Promotion, Nutrition, and Oral Health. And then that chief directorate with other clusters report to a branch called Primary Healthcare, and then that DDG reports to the Director General.
Okay, interesting. And then just as a follow-up, in your office, so I think it's a little bit confusing, but I think it's also understandable. How is your office structured, for instance, for it to be able to fulfill its functions?
Now, the structure of the Directorate Oral Health, you've got a director, you've got 2 deputy directors, and then you've got admin staff. So it's supposed to be 6 at national level. Deputy directors, one deals with primary healthcare, one tertiary services of oral health. And then you've got a PA to the director, and then admin staff that is for traveling, budgeting, and all that. That's the structure. And then the purpose, as I said in the morning, we look at policy formulation, interaction, or liaising with other stakeholders, norms and standards. That's what we do. Now, budgeting. What would happen would budget for oral health directorate, mostly it's administration, salaries, traveling around, that is the goods and services we have. And we don't have transfers. The major budget that we have now is we buy toothpaste and or let me say oral health preventive material, which we distribute to district. But mostly it's policy making. So our budget is on goods and services. We do not have a budget that goes to provinces, either for capital expenditure or any form of transfers. There are units or clusters that have got transfers. For instance, HIV and AIDS or hospital services, they've got a chunk of their budget on transfers where they get money from national and then transfer to provinces. We do not have that as a national directorate of oral health. We have no budget that goes, we transfer to provinces. So the budget we have is strictly for the administration of the office.
Okay. Thank you, Dr. Mkuba. I think it's clear. I would like to ask some more questions, but we don't have the full day. So I think the question that was supposed to be asked was, what is the ideal structure and location of oral health within the health districts? As you know, there are 52 health districts. Now, Dr. Poso went into a little bit of detail regarding their structure in Gauteng. Do you perhaps want to leave out Gauteng for a bit? But in your own view, Dr. Poso, what do you think is the ideal structure? And how should oral health be located within the district health model?
Okay, it's difficult to address in terms of what is the location, exactly where it should be located. Because I think what is most important is the integration of oral health within the broader healthcare system, right? So I think it's not that material so much as in the location, but the integration within other health programs. Because I think for a long time, oral health has been run as a vertical program, and we want to move away from that, and that is why we are faced with the problems that we are faced with now, the limited budget allocations that we have, and the general exclusion from policy making and decision making in our departments. So I think where oral health is located now at provincial level is within a branch called Hospital Services, and our chief directorate is Oral Health and Therapeutic Services, and that assists with developing the multidisciplinary approach in delivery of services when we have that amalgamation between oral health and other health programs. And we have a lot of collaboration with other departments, as I've mentioned before, school health services, public health, HAST. So those kinds of collaborations are key, and not so much the location as such.
Okay, that's fine. Dr. Mtetwa, in your experience, having been in the system for as long as you did, what do you think?
Thank you. I think the problem is the structural makeup of this country. We're running a system where you're running provinces, 3 spheres of government. So you've got your National Department of Health, provinces, and local government. Now, provinces get a budget. They would then allocate, accordingly between district health, hospital services, and the various programs. So I agree with Dr. Poso that it's neither here nor there as to exactly where you are located. The main thing is, how do you leverage on your budget where there are synergies with other programs you maximize for the sake of oral health. I mean, gone are the days, colleagues, before 1994 when we had it good for programs. Programs were run vertically. Vertically just means you were given the money to run everything that you need to run about that program. You had a budget to buy cars, to promote health, to employ staff, recruit, whatever. I mean, but that was all lost for the good in the name of integration post-1994. So the challenge we have now is that, for me, the bigger challenge is that we need to almost educate the broader health system as to the importance, relevance of oral health, and then see where we can maximize. Because if we're still trying to argue our own budget, it's got good and bad. It's good that you control your budget, so you determine what you want to do, your priorities. But it's also bad because with a shrinking economy, you end up with a much, much smaller piece of the pie. So you will not have enough money to do other things. Whereas if you accept that oral health must be part of general health, then we are able to argue on the basis of priorities and networking and whatever. Just to give an example, a lot of policymakers do not understand that oral health is not just about primary health care. A lot of people think oral health, primary health care, that's it. They stop thinking when they think of school health and clinics and mobiles, and that's it. Yet there's a big component of oral health sitting in hospital services and secondary, tertiary services. So I've always been one of the biggest advocates that let us use the bigger slice of the budget. For example, KZN gets about 50 billion rands of budget for health. But if you were to slice it to all the programs, HIV, TB, rehab, all of those, you'll find that oral health will end up with not even R1 billion. You might get R500 million. And what are you going to do with that? But if you allow it to be integrated within non-communicable diseases, then we are able to leverage on other programs. So I think, for me, I'm agreeing with the colleagues that let us not be so preoccupied with that. Let's just accept that some of it will be primary health care. So we'll dip into the pot of primary health care for primary health care related oral health. We'll dip in the pot of hospitals for hospital-related expenditure. And therefore, you've got a bit of a better expanding pot that way. The last comment I want to make is we do need some consensus, although I don't see it coming, that because we've got 9 provinces, it will help if we all had a similar-ish structure. That would help because, for example, Gauteng and Western Cape, I think oral health is within hospital services branch. in KZN, we are within non-communicable diseases. Limpopo may be running slightly different. Mpumalanga could be something else. So I think that's one of the fight we need to have as a profession, that let's at least standardize that all provinces are running more or less a similar structure. That way we're able to argue for the same pot as general health. Less about we want our own money to do our own things.
Sure.
Thanks.
Okay. Dr. Ramdao, I'm not so sure where you are based. Are you in a management position? But does the Public Oral Health Forum have a view on this issue?
So, as Dr. Mtetwa mentioned, if you look at the different provinces, different districts, it's all structured differently. There's no universal sort of structure which they're following. Like Gauteng is more well developed. They'll have a director for the district, a deputy director, clinical manager. Whereas if you look at Eastern Cape, it wouldn't really be structured in the same way. A lot of times with oral health, like for example in the Eastern Cape, you'd have a coordinator for a district, but again, that coordinator is just voluntary. It's not really a position that they've been appointed to. It's more on a voluntary basis. So there's no structure to it, so it's not the same in all the districts. And if you also look at the other professions, ideally we'd like to have like a chief dental assistant in a district, or a chief dental therapist who they then report to, and who better understands their challenges in terms of like planning and stuff. So if you look at it, the structure is different amongst the provinces, and I think that's where they need to sort of try and get a more of a universal system in place, where if you compare Gauteng and compare Eastern Cape, they shouldn't be like miles apart.
Okay, awesome. Yeah, and I must say I do follow the arguments that have been made. But structure is important, always. And Dr. Poswa, just remind us again, you spoke about the structure of district services in Gauteng. You maybe just want us to, so that then we can then go to what Dr. Ramdao is saying, that we have a, so let's assume that Gauteng has got a model and we think that the model is good. Perhaps that is the model that we can use then, in trying to standardize, right? Yeah. Do you want to explain to us how your model looks like again, Dr. Poso? I know you did so in the morning.
Okay, so at district level, you have the district being led by an oral health clinical manager, right, who is supported by province through a clinical manager, right, which would be myself. We provide strategic leadership to districts. And they then get operational support from leadership within the district, which would be the director of PHC services. So in a way, you would say the oral health clinical manager at district level has dual reporting lines. They report to province and also to district. So getting strategic support from the district and operational support from the province and operational support from the district. The oral health manager, the district oral health manager, is then supported by sub-district managers. As I've said, I'll give an example of Johannesburg Metro District that has five sub-districts. So in those sub-districts, they are assigned oral health managers. Now, these are clinicians that are merely assigned to those posts to assist in the operational running of the district. They're not in appointed posts, which is the challenge that I raised, that it's taking people away from clinical services and putting them in management positions, one, without having capacitated them with the management and leadership capabilities that they need to run, and also compromising the services that should have been run while doing their clinical work. Now, those sub-district managers then manage the clinics within the sub-district. Each clinic has a head of clinic, which would either be a dental therapist or a dentist who's heading the clinic, leading the team within the clinic. So that is basically the structure there. Now, let me go to what
Dr.
Dr.
Ramda.
Dr. Ramda is saying, that what we are looking at as a province now, as we are looking at reviewing our organizational structure, is making sure that there's career pathing for all categories of workers, for all categories of oral health professionals, because you found that in the past, it was mainly dentists who were getting leadership positions, but we are crafting an organizational structure now that gives equal opportunities for career growth and charting career pathing for all categories of staff. And it's actually supported by the OSD dispensation, because there are chief posts, followed by assistant director post, followed by deputy director posts for therapeutic services, which would be your dental therapists and oral hygienists. So the OSD dispensation does give that allowance for career growth and leadership development for all categories of staff. So that's something important that we need to bring into oral health leadership structures.
Sure. Any comment on your part on this one, Dr. Mteto?
Yeah, well, for some time we've looked, when I was here in KZN, definitely, we did look at the Gauteng model, because I think the difference from what Dr. Poso is saying, and it's correct that the OSD dispensation does allow career pathing for all the various oral health professionals. There are two challenges. The first challenge is if it's not structured and written in structure and approved as such, then this whole voluntarism thing and assigned responsibility becomes difficult to manage, because people then say, well, it's an added on responsibility, so I'm not going to do it. So I think whatever we agree upon, it has to be in the structure, signed for, and approved. So that's the first point. The second point is all of these structures cost money. They cost the budget. So often what happens at the district level is that people are, because at that level the focus is more on operations and service delivery. So you also don't want to create it too top heavy, that you've got too many managers and less production, because that's another balance that the province will also look at. So you end up with this situation where you're assigning these responsibilities. So one of the options that we did consider at some point is that maybe if we leverage on clinical managers, because clinical managers by OSD perhaps in hospitals or facilities, they are responsible for their hospital. But maybe if you added responsibility on the clinical managers to not just look at their hospital, but look at a sub-district rather, so that you broaden their span of control and influence. Because you might have a clinical manager, but only managing 4 or 5, staff. But you'd rather have a clinical manager broadly used. And I think that's why we started thinking, maybe let's appoint them across the 11 districts so that their duties extend beyond just, their hospitals. Because you're trying to leverage on budgets and all of those things. But I think if Gauteng model can pass scrutiny, certainly budget scrutiny, it'd be a good example to compare and use. But the challenge becomes the budget, that at that level of care at a district, you are very sensitive to operations and production rather than the top-heavy structure. Yeah. But so I'm all for clinical managers or deputy directors and dental therapy and oral hygiene, AD, that's all fine. But add a bit more responsibility, because if you don't and you just want them to be responsible for a clinic with 2 or 3 staff, you lose the debate, certainly with your OES and other things to justify that responsibility. Yeah. But I think it'd be good to see that. And again, if we do, let's standardize it across the country if we can. But there's very few things that South Africans across the 11 districts we agree on. So if we can agree on that one, that'll be good. Each province does it slightly different.
If 3 community
Yeah, yeah,
Community dentistry could not
I cannot
agree
agree.
on the scope.
And they're all within one province.
Okay, and I did make a disclaimer earlier on that I'm very unfortunate that I've never actually worked in the public sector. But, you know, I gather that, you know, there's you know, either there's a tension or a bit of confusion regarding, you know, oral health services, you know, because, you know, in certain instances, it's very clear in clinics and so on, it is very clear that, you know, oral health services are, you know, are a function of the sub-district. But in certain instances, oral health services are located in secondary hospitals. In certain instances, in tertiary hospitals. You know, is there a way of harmonizing, you know, these levels of care and structure, you know, between, you know, sub-districts and districts and, you know, I'm not too sure if tertiary hospitals fall within districts. I stand to be corrected. What do you think, Dr. Mkuba?
For me, what is important is to have the program in a structure. If you look at the district health plans, when were they crafted, I think, is it 7 years or so ago, we do have oral health as a program in a district. It's there. I think what Dr. Mtetwa and Dr. Poso were talking about are the people that are leading or having positions to lead the program. But it is there. For me, that is very significant, that you have oral health as other programs, HIV, TB, in the district health plans. You have that. I think there was a structure that we contributed on, Dr. Mtetwa, if you won't remember, at the district level about progression of dental therapies and oral hygienists. We did that with Mr. Murawan. So for me, that's very important that you do have the program in the structure. Then how to implement it falls under hospital services, it falls under whatever in the district. That's a different matter. Because when they do their district health plans, oral health has to have what is their plan for that year. Now, oral health, for me, like all other programs, has got a primary health component, secondary and tertiary and quaternary components. It has done. It has to be here. If this is a quaternary hospital, it has to be here. However, the services that are provided at this level cannot be this primary component. So you have to have, under district, a CHC that has got oral health with its own package, and then you've got a district hospital, tertiary, and all that. So it has to have that. What Dr. Mtetwa was saying, this is what the policy is trying to address now. Because if you go anywhere in South Africa, you'll be told, no, oral health is a primary healthcare approach. Just before I close, we had a problem in Eastern Cape, which dramatically changed the way they see oral health. Oral health was at Frere Hospital, which is a tertiary hospital. But it was budgeted at primary health care, Mbilweni CHC. They had 7 dentists in there. Now, after they were doing all sorts of things, fractures and all that. Then after some time, when the district manager, new district manager came, he said, no, we cannot pay salaries of people in the hospital. They must come here. I remember they phoned me. I said, Dr. Mkuba, we don't want to move from the hospital to CHC. I said, guys, please move. Within 2 months, they are going to take you back. Because when they took them to the CHC, which had beautiful 5 chairs, there was nothing at Frere now. But Frere cannot refer to a CHC for a fracture or a bullet wound. It could not do that. You cannot refer down for a specialty treatment. So immediately, within 3 or 5 months, they created a dental facilities at tertiary level, Frere, that was managed by dentists, paid for everything by dentists. by the hospital. So you had this separation of primary healthcare package at the CHC and the tertiary service package at the hospital, funded at that level. So you need to have that primary, secondary, and tertiary services in of dentistry.
Interesting. Okay, before we move off this one, colleagues, does anybody want to comment, raise a question on what has been presented so far?
Packages of services and at different levels of care.
Or sufficiently confused? Okay. All right, that's fine. Let's just move. So, and very related as well. So the levels of care, and I think this one should be fairly obvious, but maybe not so obvious. Dr. Mkuba, what does your document? Is it a 2002 strategy or is it the 2010 strategy policy? That defines the levels of care and how they should be structured within the districts.
The level of care provisions, which we call primary health care approach, is not necessarily an oral health approach. It's all the programs. You have to have a community-based approach, that is prevention outreach, and then CHC or clinics, that is primary health care package. I think there is a comprehensive primary health care package of all programs. There's a document. I think oral health, then it was page 25 of that, which was the package I showed you this morning. But in that document, which is a comprehensive primary health care package, for TB, it will tell you what is that. For HIV, for all that. So you have that. I think also we have a district hospital package for all the programs. Oral health, it does have a package in that. But what happened when the policy was developed in late 90s and early 2000s, we had to focus on strategy for oral health for primary health care. That's what I showed you. I think it's a 2002 National Oral Health Strategy, which had a package. If you look at that package, it's a primary health care package. It does not have secondary and tertiary services. Now, what the policy, 2010 policy that is still not yet approved, but we're building on that, was to expand, saying we need to be integrated to all health programs. Our HR, access to oral health, to oral health services. But we need to do that based on the primary health care approach of the country. That each program has got primary health care package, secondary, tertiary, and quaternary services. So this is what we're doing now to outline those services in the policy. That at secondary, this is what we need to have. At tertiary, this is what we need to have. Both the services and human resources and other financial resources, so that in all level of care, you have oral health services.
Okay. All right, that's fine. That's fine. I think your response is based on policy, albeit that is a policy that is not yet approved, but it is there. On the ground, in reality, what is the situation, regarding the provision of services, Dr. Ramda?
So, if you look at it in reality, again, services are not available equally throughout districts. If you look at most primary health care facilities, you would only have extractions available. Certain districts, there's no secondary care to refer to. Tertiary care is mostly maxillofacial. So if you look at most of the districts, all of the dental services are not available. So it's only where they have academic institutions like in Gauteng or Western Cape where you would find more specialized services like perio or orthodontics. Whereas if you look at other provinces like KZN, Eastern Cape, they're non-existent. I don't think there's a single periodontist in KZN who works in public service. So those levels of care are not available. And dentistry then just becomes primary health care.
Okay. Yeah, and I think just to bring the discussions home, again, if a dentist is employed in a Tekwini district, I don't see Dr. Mesra, precisely where should that dentist report for duty, right? Should the dentist be here? Should the dentist be at you call it the secondary hospital? Should the dentist be at the CHC? And exactly who should be where? Where should the dental therapist be? Where should the oral hygienist be? Just broadly, I know, but I'm just trying to make this discussion practical, right? So that we don't talk in the clouds, right? We just have to be very practical. Dr. Poso?
Okay, I think where should who be will be difficult to work out with the existing infrastructure we have currently. So, for example, in Gauteng province, we have over 300 CHC and PHCs combined, right? And just under 30 hospitals, which includes your tertiary hospitals, regional hospitals, and district hospitals. So in the whole, we have, in the majority, PHCs and CHCs. So the staff that we have will have to be based in those facilities. We just have to design the services that they will be offering within those facilities. But there's another dynamic now that comes into play here when it comes to the allocation of primary, secondary, and tertiary services that is brought about by the staff establishments of our oral health departments. For example, in Gauteng province, we have a total of just over 230 clinicians, right? Clinicians includes oral hygienists, dental therapists, and dentists. Out of that 230, 70% of them are dentists. And we want to focus on primary health care service provision, and the infrastructure caters for primary health care service provision. So there's that imbalance. So this is something we have to seriously relook and reconsider as we are planning going forward in terms of this number of dentists in relation to number of dental therapists and oral hygienists in the system. Is it working for how we want to design primary, secondary, and tertiary levels of care? So we have to look at that first, relook that, and reconsider and inform our policies and our HR plans going forward. And then in terms of the actual levels of care, we obviously have to focus on, we have to have a strong focus on primary health care service provision, then followed by secondary, then tertiary. We do have a strong tertiary service provision in the province for the reasons I've mentioned before, and also primary health care. It's the secondary level that we are trying to bolster. As I have said, that we want to expand specialized services into primary health care and district services by upskilling clinicians to be able to provide some of the specialized services at that level rather than referring to tertiary services.
Yeah. Okay. Then let's just, even make it even more basic. Is there justification, Dr. Mthethwa, to have dentists at primary healthcare level, even at CHC level? CHC. Yeah, is there any justification?
Okay.
Given, all the, the policy prescripts and, what we really want to achieve, in the health system.
Yeah. No, thank you. I think that's an area that I personally spend quite some time on. And we must be bold as the profession. We must agree once and for all, and we must draw a line that progressively accept the imbalances of the past and then draw a line from a certain year going forward. And this is how, in my mind, we should all agree to structure it. A health system, it will mirror more or less a medical system, unfortunately. It's a pyramid. At your very bottom, you've got your primary health care, school health, mobiles, platform, outreach, and all of those primary health care processes. Then you've got your secondary level, tertiary, and quaternary. The higher you go the pyramid, the less numbers, volumes of patients that should be pushed up there. And the higher you go the pyramid, the more skill set you need for the person who's at the top. So let's bring it practical. This hospital that you see is a regional hospital. It's specialist-led. In other words, it's not a nurse or primary healthcare driven. They are specialists. So dentistry, we've got to do something similar. In the primary health, and then we must all play to our strengths as the multidisciplinary team of oral health professionals. All of us must do what we're trained for and do it so well that we then easily follow that model. So I'm answering your question directly. At a clinic, clinics up to CHC, I would argue to a certain extent up to a district hospital, which is level 1, I think you should have dental therapists there and oral hygienists only. Only. Then from your regional level, which is this hospital, upwards, you introduce dentist there. On a tertiary level, you introduce dentist and specialist. At a quaternary level, you've got specialist and sub-specialist, right? So there is no reason you should have a dentist at that primary healthcare platform. What that then means, what that does then, you are also informing the training platform, the universities. Then it means you must train more of your base because it's a pyramid. Yep. You need more manpower at CHC. So you train more dental therapists and hygienists. But when you train them, create more posts at the base so that they're your first line to sift and case find and all of those things. And then they refer. In any case, in their scope, they cannot do those things. So they refer up. Then you've got more dentists sitting at regional, tertiary, and quaternary hospitals, and then specialists. And then you've got a seamless referral system. What practically that would mean? It would mean that, of course, those people that you've already employed in the system, you leave them through attrition. Over the years, they'll get old, they'll retire, whatever will happen, But eventually you draw a line. You say, from 2025, this is it. You inform your HR, you inform your planning, you inform your organizational development people. They write the organogram, the staff establishment that you're talking about that way. And you also inform the universities to say, train so many oral hygienists and dental therapists because this is the burden, because this mirrors the burden of disease that we have. So train more, primary health care, be strong there. So unfortunately, this then means, this is academic work, it then means that we need to know how many should we train in at what level? Because we also don't want to overproduce, guys. It's the most dangerous thing you do. I've seen it in Europe where they overproduce dentists, they overproduce other categories. There's nothing wrong with keeping the profession a niche few. You can train 30 dentists, it's okay. Because at least if you're training few and you've got the jobs that matches your training, it's better than over-training and people are unemployed, because your system is skewed. So okay, I would put CHCs, clinics, dental therapists, hygienists, dentists there, and then whatever that formula works out, you inform the universities, train less dentists, train more hygienists and therapists, create the post, and you've got a seamless system. You train specialists, MaxFac and others in, not just MaxFac, the point was made, periodontist, prosthodontist. Was when we think specialists, we always think MaxFac. Yes, there are others. Train them, put them in the tertiary level. So I think that's a model we should.
Yeah, okay.
We should be bold as a profession and just do that and stop this bickering and whatever story. It's in the past, it happened, draw a line, and let's move on.
Move on. Okay, I'm happy that you are clapping because, the DPA predominantly consists of dentists. And they may be unhappy that we are talking them out of work. So. Okay, and then there's this issue of rural provinces. Actually not even rural provinces. I mean, Dr. Mizra was telling us about the dentists that have been posts, I think they are development posts that were created so that people from KZN can go and study, and which is great. I mean, today we had Dr. Haynes, one of the beneficiaries of that. But I mean, how many developmental posts are there? What chance do we have of having, adequately trained specialists in the what are the chances? I mean, I know that in the Northwest there's only one maxillofacial surgeon in the whole province. But what are the chances? I mean, given what's happening now, especially in relation to the rural provinces, is there any chance so that when your policy is finally approved, Dr. Mkuba, that we will have quaternary services in rural provinces, for instance?
I think there has been a huge progress when it comes to that, especially when Prof. Simon Nemutandane went to vets. For example, this year, UP, where Prof. Mapongo is, they had 4, not developmental posts, but posts that the province will send the people they want to be trained. But no province took. And it's a simple reason. Most provinces have sent some people, 1 or 2. I think this province is 4 plus 2. I think I think Northwest also has got somebody at SMU. So these posts, the challenge is with these posts, when you leave Prince Mshieni as a dentist to train as a specialist, you go with your post. The province pays you. Remember the way it's structured, if the UP, vets, whatever is allocated by HPCSA based on their resource, let's say they can train 5 or maxillofacial specialists, right? The 3 provinces in Gauteng, that budget, if UP vets takes those registrars, that's the Gauteng budget, right? So what would happen, you'll find that UP has been allocated by HPCSA. They can train 5 registrars because of their resources. But the province can fund only 2, right? So what they would do, they said, okay, provinces, do you have any person you want to send so that we can train? Because we qualify to train 5. But the challenge is this, the province must take this person from Prince Mshieni, from Livingstone, and come with a salary here in Gauteng or Western Cape, whatever it is. Now you've got a post that is filled in Livingstone, but there's nobody working there. So this is what is a dilemma with provinces. We want to get more of the people that are postgraduately trained or specialized, but at the same time, when that person leaves the post with the salary, you've got no services. So that's the balancing act provinces. I think KZN tried to do that pretty well.
Dr. Mthetho?
Yeah, no, I was addressing that gap you can get around it. You don't have to use a post in a system already to train, because that is mainly used for your subspecialist training. Let's say you are, let's say you are a surgeon already, you want to be now you are an anesthetist, you now want to be a critical care or intensivist. They use that model where you're taking your post, you go and train with it. But the KZN model of the ones that we sent, we said you must resign, so you leave the post available in the platform for somebody else to use it. And you take up a registrar post, because the registrar post is conditional. It's a contract, so 4 years, you go and study, you don't have a post, you're not holding the system. You are gone for 4 years to go and train. When you come back, you are no longer a dentist, you are now a specialist. You're not going to use that post anyway, because that post is for a dentist. You are now a different person. You come back, then we must then put you in a different post altogether. So that's what we did with Dr. Haynes, for instance, because in all of them, they were dentists, but I think they had to resign, take up a new registrar post. When they come back now, we have to create a post for them. Dr. Gumeda had to go to Ngwelezane. Haynes, I think, is at Albert Lutul and whatever. So I think provinces, I think we need to lobby, the point I'm making, we need to lobby all provinces that don't have dental schools, except Gauteng, yeah, all of us, the rest. We must just lobby that we use the registrar, the medical registrar program. Just like medicine does, they send registrars to do pediatrics and whatever. They use the REG program. They all resign as medical officers. We just use that vehicle and we introduce dentists. That's how we did it. And I think it's a better model because you're not holding the system. No hospital CEO would agree to their post being in Gauteng and whatever, because they want service delivery. So I think we need to just maximize on that for Eastern Cape and others. It is difficult, but at least we could push on the registrar post. Yeah.
Yes.
We just have one question.
Good afternoon, colleagues. I have a question. I'm a dental assistant. I've been a dental assistant for 16 years. So while we're on the subject of training and development, my question is there any possibility of us dental assistants getting further training and development in the oral health sector? Because I have inquired previously about getting further training, and I've been told that in order to study BOH or BDT, I would have to resign from my post and study full-time. So is there no way that maybe we can it can be introduced, but as an online program? Because when COVID started, we've got our graduates here who studied online and they managed to graduate, having to study online. They only went into the clinics when they had to do practicals. So I think it's something that can be doable.
I think the point is made. I must just say that I just had a chat with the lady during the breaks. But I think the point that she made is that, look, she started here 16 years ago as a dental assistant. And 16 years later, she's still a dental assistant. All right? There's no movement. All right? I suspect, it is probably the same with many dentists. You come in, post-ComServe, you're a dentist. Somebody meets you 20 years later, you're still a dentist. Okay, that's fine. I think point made. I don't know if any of the panelists would wish to contribute to that. Dr. Mtuba?
Can I just find out, the people that you said they did online, were they doing dental assisting or?
Dental therapy and oral hygiene.
Therapy.
Even the dentists.
Yes.
COVID started, they had to continue because COVID was not going to stop everything. They had to continue, but then online studying was introduced.
Yeah, I wanted to address that.
They came to the clinic only to do their practicals.
Afternoon, everyone. My name is Kulegile. I am a ComServe dentist. Just to give clarity, we just did the theory part, lectures online. But during COVID, we still went to the clinic to do our quota work, clinical quota work. So it was just only theory part and our assessment, but some of our assessment, I think when we were in final year, still fourth year, while we were still in COVID, we actually went back to do assessment, contact assessment. So we didn't do like clinical online. Yes, we are the COVID, we are the COVID graduate, but we didn't do, we didn't do everything online. We are skilled for
Okay.
COVID.
Okay. For me, it's. I don't necessarily think I think the point that she's raising is that are there no other innovative ways, right, of upskilling dental assistants, for instance. I think that is the point. It may not be as simply as she put it, but all she's saying is that can we explore alternative ways of upskilling of the dental assistants? As them being a vital part of the dental team. Okay, all right. And then whilst we are still on the issue of upskilling and specialist training. Don't we think that, the easiest way of delivering tertiary services to the communities is actually through upskilling of the dentists who are already in the system. All right, upskill them, not to the specialist level, but to a point whereby they are able to manage a lot more of what is currently being managed exclusively by specialists. And by upskilling the dentists, that could actually solve a whole lot of the problems related to access to tertiary services. What's your view, Dr. Mkuba?
Well,
not only dentists, by the way. I think it is also possible to upskill even dental therapists and oral hygienists.
Remember, skilling people is to increasing their scope of practice to some extent. They do more work. I found that for me, in the health sector, there's something we call in economics, economies of scale and economies of scope. Economies of scale is when you do one thing well to a large number of people. But economies of scope is where you do as an individual many things. Your scope covers many things. For me in the public sector, I would have a problem with that because it's like taking a specialist and putting it primary health care. Because a specialist can do scaling and polishing, can do implants, can do whatever it does. But the problem with health, you deal with one person at a time. So you can upskill somebody to do deep odont, whatever it is, maxillofacial and all that. But that person will see that patient for 45 minutes to an hour. For me, instead of having that, have an upskilled person working at secondary or tertiary level services. But at primary healthcare services, have economies of scale, where we've got a large number of people who can deal with common diseases, prevention, whatever, so that the people that are sifted through the system are a few people that those people have got skills for that, they are going to deal with them. I wouldn't
Yeah.
skill people to put them back at primary healthcare.
Yeah.
don't
No,
know.
I think we are agreed. I think we are agreed. We have agreed that at primary healthcare level, CHC, PHC, to some extent, I think that's what Dr. Mteto said. We don't also want them at secondary hospitals, the dentist, that is. However, we still have an issue regarding access to specialized services. The question I was asking is that, of course, one option is to train more specialists, right? Which is more difficult because, universities can only train 5 registrars at a time, whatever the case may be, 4 sometimes. But isn't a solution to train the professionals who are already in the system, upskill them, so that, for instance, Dr. Haynes was talking about trauma, right? Very few dentists, for instance, can do open reduction surgery, right? But how difficult is it, for instance, to train dentists to do open reduction surgery so that they can do it here at Dr. Pixley Kasime Memorial Hospital, rather than either training a maxillofacial surgeon or maybe transferring them to a hospital where maxillofacial surgeons, I think that is so the point that I'm trying to say, is it not more feasible to train to upskill the people who are already in the system? Because it is possible to upskill. That's my view. Or maybe I'm biased because I'm a dentist. I don't know. Do you want to?
Hi, everybody. I'm Dr. Ganga. I'm from a regional facility. And whilst I'm totally in favor of upskilling and that type of a thing, I just want to inquire, let's say you do train dentists from a regional facility where there is no specialist service currently. I'm just talking about eThekwini, right? And let's say you now run into complications and a challenge. Who then accepts the liability, the litigation that comes with that? Because your hospital is going to tell you you're not a maxillofacial surgeon. What then happens to us as dentists who've been upskilled for a period of 2 weeks to 4 weeks? And MaxFac says, well, you shouldn't have done that. So then we are pretty much caught in the middle. So what then do we do?
Okay, the question is still open to the panelists. Yes,
Can
Dr. Mkhubo.
I deal with this? Colleagues, we've got a scope of practice and a scope of profession from Health Professions Council. You cannot do beyond that. Most of these upskilling, Dr. Twala, are some of the things that are within our scope of practice as general dentists. But because of practice, because we're not encountering them every day, that's why people, they do this deep orthodont, they do these masters in interceptive orthodontics, but they're within our scope. So I agree with you, we can do that, so that I do not, as a general dentist, refer here for something I can do. But the only reason I don't do, because my skill has lapsed, because I'm not encountering it every day. So it's within our scope, that's number one. We cannot be trained beyond our scope. That's where the doctor now comes in. Because if you are trained beyond what your scope is allowed by Health Professions Council, we are crossing over the specialist field, then you have a problem now. You are practicing beyond your scope. But upskilling within your scope, I think this is, for instance, what Eastern Cape is doing. Eastern Cape has got somebody who's a general dentist, but it did a diploma or master's in maxillofacial. So they are doing most of the things that's the Lefoti ones, which are within the dental scope. They are doing it at Cecilia Makiwan. They've got a lady that has done interceptive orthodontics. He's a dentist, he's not a specialist orthodontist, but he's doing within her scope what is fixed orthodontics is supposed to be done. But they are doing that at Cecilia Makiwan as I'm talking to you. They are not specialists, but they are covering a large number of what you call pre-specialist procedures.
Dr. Mteto?
No, I think we more or less, I think you're both saying more or less the same thing. it depends what your end goal of upskilling. If you're upskilling to enhance the skill set that you have so that you're a sharper, better clinician, good for your patient, I think that's well and good. But not because you're upskilling to encroach or go beyond your scope of practice. So I think it's okay if you are just increasing your knowledge. And by the way, a good upskilling and a good upskilled professional will also know what not to do. Because part of upskilling you is exactly knowing what you shouldn't do. I remember at the dental school they used to say, a good clinician is the one who knows what he doesn't know. You know what you know. Once you get to say, I don't know this, then you know that's outside your depth. So okay, I think that I'm all for that to enhance your skill set, so long as obviously you're staying within your boundaries. Again, there's plenty examples that are done. But there's another upskilling where it's part of a continuum of a training towards a qualification. You're doing this diploma because that diploma will add towards your credits in future to be a specialist. So that's also okay because it's channeled towards a particular pathway. So I think we're supportive so long as there are,
Of course.
boundaries. Because that skilled, better dentist will be able to pick up cases early, know when to refer early, and all of those things are part of upskilling somebody.
Yep.
So it's a good thing.
Yes.
In a way.
And I think on the same topic, what has been the impact of the master's program in interceptive orthodontics for Gauteng, Dr. Poswa? Have you seen results yet?
We're starting to see results, Doc, because the first cohort actually graduated in 2021, right? 2022, in 2021, we started with the second cohort. So in 2021, the first cohort graduated in that year. So we're starting to see results because we're starting to see completed cases within the province now, because while they were going through the program, they were seeing those patients through SMU. So we're starting to see completed cases within the province. So with time, there'll be a scale up of output of those patients. And what is interesting to see is how there is actually transfer of these skills from these dentists that have been upskilled to their colleagues within the district. So that transfer of skills is actually helping because they're supporting each other as well. So you'll find a dentist will move from one clinic to go and work in the other clinic with the upskilled clinicians to see the patients together. And another thing that helps is having this constant line of communication with the specialists in the universities giving support in the management of more complicated cases within the clinics. So that helps as well.
Sure. Okay. Dr. Ramda, any comments, additions?
It's good, but in a lot of the provinces, dentists who are working in the public sector, for example, if you want to study a postgraduate diploma, you would have to then get try to get approval from your manager at your facility and then apply to the university. And so there's no set program that's organized by the province. It's at the discretion of your manager if you would be granted like study leave to do a postgraduate program. It's then also self-funded because most of the time there's no funding available from the province. So I think if you get support from the province, it would help to upskill a lot of the professionals. Because if there is support from the province, a lot of dentists will want to do more postgraduate programs, improve their skills, because they know they are supported by the province, it's funded, and it makes it more accessible to them, as opposed to them trying to do it on their own.
Yes. All right, that's fine. Remember, we're just trying to make the system better. All right, we're having a conversation, and certain things can be done very easily to improve the system. I mean, not everything needs a lot of money or resources to be done. I think that we can do certain things very simply, right? Just by being a little bit imaginative, maybe even a little bit adventurous, Dr. Mteto. Okay, the final issue that I want to add is that monitoring and evaluation. When you look at the South African health indicators, the annual reports that are issued by the Health Systems Trust, for instance. So we will know what is the infant mortality rate. We will know what is the incidence of tuberculosis infection. What is all sorts of indicators. But where are the indicators in oral health? It's a pity Dr. Mkloba is not here. But where are the indicators? Where can we find them?
We've got what we call National Indicator Data Set, or in the District Health System Information System. I hope I'm audible. What Health System Trust writes about, the District Health Information System has got those indicators, needs, national indicator. They've got all TB, HIV, hospital headcount. We do have oral health in that spreadsheet. We've got 8 of them. We've got a head count. We've got fissure sealants, number of fissure sealants done. We've got extractions. We've got restoration. We've got dentures now. We've got implants, max-fax, and ortho. These last 4, we added them about 4 years ago because we've been doing the 4, which encompasses the primary healthcare. So we have those indicators. I think the one that has been proposed now for the next new set is the number of schools, because oral hygienists have been saying, we go to schools, but who measures our work? So we've added that one. Whether it's going to be approved by the TAC, Technical Advisory Committee, or not, we're not quite sure. But we've added that one now. We'll have 9 approximately in those indicators.
Okay. Okay, but where are they? Where are they? Are they, in the district? You said district?
If you go District Health Information System, DHIS.
It is there.
You'll find there are quite a number of them: hospital services, HIV, TB, and then you say oral health. You'll find the indicators oral health.
Okay, and Dr. Poso, are you confident that those indicators are accurately collected, like they reflect the true picture of the burden of disease or quality of services in the districts?
The indicator themselves, yes, reflect the burden of disease, right, and the quality of services. However, we have found over the past few years that there are discrepancies in the data that is presented on DHIS, for example, differences with the data that is actually sitting in the facilities due to structural problems like human error. Data is collected to be put on DHIS by data capturers, and the data gets corrupted in the system. So we've actually now put in a rigorous data verification system in the province, whereby each facility has a data verification committee that's supposed to be representative of each health program in the clinic. And we've encouraged our oral health colleagues to be active in those data verification committees to make sure that the data that comes out is actually reliable and accurate. So the indicators as they are meant exactly to reflect the quality of services. For example, one of the indicators, which is the ratio of dental extractions to to dental restorations shows the quality of work that is being collected. Are you doing more extractions or restorations in your facility? So those kinds of that kind of data then informs us of the quality of services that is being rendered in certain facilities.
Yes. Can we improve on the quality of the data? To say, and your point is taken, but you know, are there areas of improvement that can be implemented? You know, quality control. I know you are talking about quality control, but even the information that is being relayed by the data sets, right? Because I'm just saying all these things because, you know, this is how, you know, we need data so that we can justify, you know, everything else that we, you know, if we're going to be talking about budget, if we're going to be talking about improvements of infrastructure in our clinics, human resources and so on, right? We need data, you know, which can speak for what we are talking about.
Right, so you're speaking to the relevance of the data, right? Will this data be relevant enough to inform
Absolutely.
strategic and
Yes.
operational decisions at that level? So that's why this consultative process is very important in the development of indicators, because it's actually the clinicians also who can inform what it is that they want to derive from the data. And it's actually important as well that clinicians get involved in using this data. We're sitting with data as clinicians and not using it. So we should start to interrogate the data as clinicians and use it for research, as Prof. Motloba was saying. Use it for research to inform managers and policymakers of the situation in the ground from the analysis of the data. So the data, yes, you're right, needs to be relevant as well in order to inform evidence-based practice and to inform policy.
Absolutely. I think it ties in well with what Prof. Motloba was saying earlier on. Okay, we are just about to wrap up. Any questions from the floor? Okay, that's fine. Okay, in closing, to our panelists, Dr. Mkuba, you know, as your parting shot, what is the one thing that in oral health we can do better?
For that, there's a colleague who asked me about NHI and oral health. I think in the document that we have, why don't we have maybe a specific chapter on oral health? I just want to say, when it comes to a policy document, a bill or a regulation, let's look at it, colleagues, not as our oral health not as a separate chapter or a program, because they are easily left, especially if your program has got very low or absent mortality. Because in health, the higher the mortality, that's where the funds will go. Now, I think we addressed this thing 2019 before COVID. If you look at the structure of the National Health Insurance Bill, there are few places where I said, let's concentrate to make sure that we are part of it. I think there were three. One was the pricing model. One was the committee for basic service packages. Let's comment in such a way that oral health form part of that committee. Because if you are part of the service or basic service package, then if there's an oral health person in that committee, then we will craft our packages as oral health. Rather than writing oral health package separately, let's craft that section so that we're part of it, even pricing and other things. So if you don't see oral health chapter in the NHI, it does not mean we're not there. We presented with Prof. Mutandan, I think last year during COVID, in the portfolio committee, in such a way that you structure the construction of those sentences so that as oral health program, you're part of that. So don't look for oral health as a separate, but look at the structure of the document and see if we are part of that. Now, what can we do better as oral health program? Number one, as professionals, let's be professional as oral health professionals. Dr. Mtetwa knows, because he worked as a provincial coordinator, I almost visited all provinces. One of the main things I find when you go to the provinces, oral health professionals, baya doja. They come at 8, they leave at 11. I had a very sad interaction with my colleagues in 2020, where they objected to be defined as an essential service during COVID. Oral health dentist said, no, Dr. Mkuba, I'm going to stay at home. I'm not an essential service. I said, you cannot be. What COVID is doing is to conscientize people to what we've been doing all along. Mask, washing of hands, gloves, and all that. This is our core function. Why are we not essential? But this was shared with people, oral health professionals, who didn't want to be seen as essential service during COVID. Then I said, okay, no, that's fine. But we had a document with the university which put ourselves as essential services. So I said to, especially the one in Eastern Cape, if you don't want to be, that's fine. Tell your manager you are not. But remember, 5 years down the line, when they restructure salaries and all that, they said, okay, we'll start increasing essential services staff. Don't come back to me and say, Dr. Mkuba, as oral health, we're not factors in salary adjustment as oral health services. So my point, Dr. Mtetwa, as professionals, let's live as professionals and uphold our profession as professionals. For me, that would be the basic, and then we build on that.
Okay. No arguments, right? Sad but true. Dr. Poswa, what can we do better?
There's a lot we can do better, but I'll just talk to one element and follow exactly on the thread that Dr. Mkuba was alluding to. So we have a lot of challenges, colleagues. All of the nice policies and strategies and upskilling programs that we put in place are being constrained by structural challenges like procurement of equipment, procurement of consumables, and then our program doesn't move forward because we can't get the material and the equipment that we need. But let's not despair. But also on the vein of being professional as oral health care workers, one part I want to talk to is that of clinical record keeping. The clinical notes that we write, colleagues. I think if we go back now to our clinics and look at the files of patients that we've treated and see is that how we were taught to write clinical notes. And that's a big gap. And that is one area that leaves the department up for litigation, that compromises the department when it comes to litigation. It actually even compromises the quality of service that you've rendered to your patient. So let's make sure that we focus on improving the way that we record, that we do clinical record keeping, that we record our clinical notes. Let's improve on that. And as managers, let's do audits. Let's audit the records and make sure that we improve clinical record keeping in our clinics. Let's actually improve clinical governance as a whole within our facilities. Let's make sure that we are drawing up standard operating procedures, clinical guidelines, and conducting clinical audits within our facilities. Let's just uplift the standard of clinical governance in our facilities to improve our clinical practice. Thank you.
Dr. Ramda, what can we do better?
So I think they've covered it well, but going back to Dr. Mzimkulu's presentation earlier, where he talked about the basic dental services, where you have your examination, your bite wings and fillings or extractions, I think that needs to be standardized throughout, so that if a patient goes to the Eastern Cape or goes to Gauteng or Northwest, they get the same treatment. It's not that I went to one particular facility and they only do extractions there. If I go to another facility, then I can get fillings done there. Those services need to be available at all the facilities, and it should be standardized, because all of them are government facilities, all of them are administrated by the provincial health departments. So the services should be standardized across all of them. And I think that's where the issues come up, because within provinces you would find that a certain facility would have a broken chair for years, and nothing is done about it, nothing is done to improve it. So I think going forward, the only way to improve oral health services is with the evaluation and monitoring, but not of the data specifically, also of the services that are available, to ensure that equal services are available throughout the districts.
Yeah, I think just to, just follow up on that and what Dr. Mkuba was saying, and to some extent also Dr. Poswa and Dr. Ramda, because I meet many dentists, through workshops and conferences. So there's this dentist, he's working in somewhere in the Eastern Cape, rural area in the Eastern Cape. And then, he tells me confidently that, look, in his clinic, or the clinic that he's working in, he does 10 extractions a day. Okay, and then that's it. And then I ask him, what happens to the 11th patient? He says, no, they have to come back the following day. True that. You can identify?
I'd just like to say something. I can't identify. Because really, look, I work at Prince Machine. We have a large patient base. And I can understand when Dr. Ngube said that, some clinicians dodge. The issue I have is where I am and where we all are. I think when you see such a large number of patients, everything else suffers, including the actual clinician. And when the clinician suffers, then the services we provide suffer. Our medical notes suffer. I mean, I appreciate this forum so much so, and I hope we have more of this open conversation, because I feel one thing that is lacking is the support for clinicians, our mental health. I mean, I hear the Eastern Cape, wow, 10 extractions. On Tuesday, I was alone, and I understand these things happen when you're alone at a hospital. I saw 95 patients by myself. And really, I have nothing to complain about, because it doesn't happen all the time. I have a supportive, our operators are very supportive. It doesn't happen all the time. And we know sometimes, we have to compromise.
Sure.
But I just feel there should be more of these forums where we sit down, and instead of bringing about problems, and we should have a discussion where we find solutions. Because to bring a problem to a table doesn't really bring much in terms of solving it. It brings more anxiety, and it's fine to just pile on problems, but it's nice in the sense where you bring a problem like, okay, this is a solution. So I just feel like with forums of this, maybe the staff should be a bit more supportive, where we have avenues, we have communication, where we can sit down and like, okay, you have this issue, that we could solve it this way, or...
Yeah, and also to include the rest of the team, right? So it's not only a dentist's, process, to... Yes, ma'am.
Just to add on what you just said now about patient, like the person who's working in a rural area seeing 10 patients. I don't know the reason, but I do my outreach in Komane. It's a rural area. And when I got there, I mean, the facility, the chair doesn't work at all. It doesn't move like up, and it's in one position, you know. So I can understand. At first, I will see like probably 30 patients. I mean, you there, those people cannot come to, you know, to our hospital. But after some time, I started suffering from back pains, you know. And it's, you know, at some point because we're not supported, you have to have a cutoff as a, you know, dental practitioner to say, I can only see 10, you know, because that's what I do now. I'm like, I can't go beyond 15 or 10. I actually say 10, then the 5 are emergencies that come on that day, because I'm working at a facility that, you know, like it's, with outreach programs, it's very sad what we actually experience, you know, as especially as ComServe. I'm a new dentist, I'm a ComServe dentist. It's very sad how the outreach programs are actually ran in, you know, in the province, being here and sharing with my other colleagues, you know. So it's not that we are dodging or we don't want to serve the community, but we are also not, like she was saying, we are also not supported, you know. And for us as ComServe dentists, sometimes when you go back and I asked about this facility, like, why is the facility like this? Because most of the outreach programs, they are under a hospital, they are given under a hospital. Like probably with where I am, it's under the hospital that I'm under. And you ask this question, like, why is the facility like this? They'll tell you it's been like this for 5 years. You must just improvise, you know. And those are the things. Just going back to what Dr. Mteto was saying, I think, and everyone in the panelists was saying, I think we really have to go back to our structure, you know, and review the structures that we've put in place. It's not just us putting people into positions to say this and that, but let's go back to see if all the structures that have been put in place, are we providing or are we getting to our objective of what needs to be done in our oral health sector, and also standardize everything provincially. If there's one province that is actually, you know, doing well in that oral health, you know, in the oral health sector, like in terms of provide, like their structure moving that way, then let's implement the structure across boards or across provinces so that we can, you know, it can be better, it can benefit everyone, the patient and also the dentist, because we can't also always talk about patient care, but we also have to be cared for so that we better provide for services.
Absolutely.
Can we take one more comment?
I'm coming again. I just want to comment on what Doc was saying regarding the fact that, yes, this is a platform where we can talk about, well, it doesn't help to just talk about issues but not coming up with solutions. So I'm going back to my initial question, where I don't think I've been answered based on I don't know if this platform will help me, but we'll see. What is, maybe if, can there be some form of direction or clarity or something, like some form of hope that is given in terms of periodontics in KZN? I just
Yeah. Okay. Thanks for bringing it up again. It's Dr. Mtetwa cannot run away from KZN problems. Okay, let's have. Okay.
Good afternoon, or almost evening, everybody. I'm Dr. Shoaib Akbar. I work at a district hospital facility, and I think that, you know, by having dentists employed at community health clinic level, it's actually created a problem where the package of service that's offered by the CHC is not in keeping with the scope of practice of the dentist. So I'm sitting in a situation where I'm getting referrals from a CHC for simple things like fractured sixes and fives, where it can be managed at the CHC level by the dentist, but because the scope of practice, the scope of the package of service does not provide for surgical work to be done there, those patients are actually being referred to the district hospital. And if it's not coming to this district hospital, it's going up to regional or even to tertiary level. So I think in terms of upskilling within your profession and within your scope is what we need for those dentists that have maybe lost the skill or their skill have lapsed, so that at the moment where they are at the CHC level, they're there already. Let's just face it, they're there. So why can we not use them to the full extent that they are dentists and they can manage those simple complications that are created in that clinic instead of having to refer that patient somewhere else? The other problem that I see is where patients are presenting at a CHC level. They need to be referred to tertiary or quaternary level, but they can't do that within the current district health system from where they are. That patient needs to be referred to district or to tertiary level in order for us to then further refer the patient onwards. It doesn't make sense to transfer the patient from one institution to another institution just to be referred to the third one. So can we maybe not look at saying that a dentist at a CHC level who's employed there, who's already there, can make that decision to say that this person has got a fracture, needs to be treated by maxillofacial, they can refer the patient directly to the tertiary hospital instead of referring to the district hospital where there is, or a regional, where there is a dentist with the same qualification as a CHC level dentist to then say this patient needs to be referred onwards. That is where I think a lot of the clogging of the system can be unclogged, where the patients don't have to spend extra time, money, effort to get to another hospital just to be referred onwards. And where complications can be managed at a CHC level because there is a dentist there. Sure, they have some problems in terms of infrastructure and equipment, but if you look at what the cost of that infrastructure and equipment is compared to the service that will be offered and the clogging, the declogging, decongestion of the system, I think that will be a lot more beneficial going forward. Thank you.
Good. You have another hand?
Yeah, I knew there were questions. I was wondering why people were quiet. One more.
Good afternoon. I'm a dentist at Harry Gwala District, Christ the King. So my question is basically KZN based, Dr. Mteto. So I just also want to add on to what the dentist at Prince Mshieni said. So you find that we do not have support. I was a ComServe and Dr. Haynes had left. I was alone. I saw about 64 patients, 70 patients. It could go up to 80, 90 if there is no cut-off. So you are alone. You basically we are based at, it's at a hospital, but then the dental department is at a clinic. So initially, we report back to the hospital. There's no other oral person who's basically there as the manager or whatnot. You just get a medical, it's basically medical doctors who are there. So they do try to assist, but then it's just the system. So in that case, you get like equipment. We can't get equipment. I've been there, I've been motivating, but there's nothing that happens. So where do we channel our, to get assistance and everything? Like even with same, the load of patients, how are we basically being, I don't know, but yeah. Besides even that, even besides just patient ratio, what's happening with us? Yes. No equipment, the chair is basically lying down. You request, you motivate, but nothing is being done. So.
And I'd like to submit her question in with the patient ratio, primarily because it keeps coming up, not necessarily in this platform, but
All the
almost
time,
everywhere,
yeah.
all the time. But we were concluding.
Yes, we are concluding. Dr. Mtatwa, I know that you've been out of the oral health system for some time, and for that reason, you are partly excused.
Yes.
I'm sure if ever you, but look, I'm sure you still have contributions to make. I think do that, answer the questions that you are able to answer, and then, finally, just tell us, in your view, what is it that, can be done better?
Whew. It is difficult, colleagues. The structural challenges have always been there in the province, and I'm sure other provinces, infrastructure breaking down, the chair that's not moving, and all of those things. The number of patients that are coming through the door, the numbers are high in certain clinics. But I think what compounded it is the shortage of not being able to replace the post. People have resigned or left and their posts have not been filled. So I don't know, for instance, how many of them are there to answer adequately, because if you've got 2 or 3 operators, maybe a dentist, a therapist, you could share the load. But in most facilities, you find that we have not been able to replace the post due to budgetary cuts. So we are in a very difficult situation as the health system, I think, as a whole currently, that the post available and the funding is just not enough against the workload. So I suspect a lot of these issues are to do with that. If it's not the post, in other words, the post is there, the manpower is there, then it's down to clinical leadership, which is the biggest gap we have. Just leadership. People willing to stand up every day leading. Whether you are a manager or you are whatever role you are placed in the health system, we've got to lead. Things do not happen by accident, by chance. It takes people, leaders, to raise and fight. It is difficult. The people sitting here will tell you, things do not happen. You don't just send registrars. For now, you've got to go fight against other disciplines that this is more important than this. So for me, clinical leadership, important, all of us making an impact and the difference where we are. And there is no big conspiracy against us as the profession or oral health. It's all down to the individual responsibility. Opportunities are there. We just have to take them head on, fight for what you believe is right. Those issues of NSIs and everything, you've got to go to the medical manager. It's a medical manager, I've been sending these NSIs, why are they not moving? Go to the CEO, go to cash flow and make your case and say, I want this thing done. But a lot of it's attitude and it's leadership that you're there. So leadership can make or break the system, I agree. I know some cases dentists do that, but the medical manager or the CEO would not approve those things. So there's a lot of those challenges. But for me, the parting shot is let us try and make a difference. Let's lead, let's influence, let's make a difference. Let's not just be comfortable to come to work in the morning, collect a salary month end, and that's it. Make a difference when you are there. Sure. Thank you.
Yeah, yes, I'm with you. So, colleagues, so it's... Yeah, yeah.
So 5 years ago, we made a choice that KZN had no specialist services. We analyzed the specialists that are there, attrition, who's going to retire, and there was nobody. But we had to progressively start somewhere. So we wrote a document and said, let us train registrars, send them off in batches. The idea was to take the first 4, because remember there's only 100 registrar posts in the whole of KZN. You're fighting with psychiatry, medicine, everybody. There's no separate pod for dental. So when you're sitting there in a boardroom and the Prof. Makero from pediatrics says, why should you train an orthodontist? You have to justify every post. So we then said our biggest burden is trauma. So maxillofacial were first. The second biggest was prosthodontics, because we had nobody at all. So that then the prosto went through. And the third was orthodontics. I think the register that went out are those three: prosto, ortho, maxfac. And then the idea was that when they come back, like Haynes are now back, then the next batch you'll do the other disciplines. So perio was not forgotten. It was just going to be in the next batch. You could not have 6 or 10 posts all at once. The registrar committee, choose your battle. We're only giving you 4 posts. Which ones do you go for? So we said priority is maxfac, prosto, ortho. When they're done, we'll then do perio. So again, it's leadership now that whoever takes over from me must now take the fight and say, the next batch, I want perio, I want whatever else. But perio was not a priority then. It was maxfac, because that's our reality, that we've got more trauma here.
Sure.
So there was some method in the madness.
So my if, and it's, I don't know, but I would say the answer lies in what has been discussed here today. Right? We went into detail regarding the structure and the programs, and how, as oral health, we should, find a way of integrating into the health system value chain in general. Right? We have to find a niche, a space for ourselves within what everything else that is happening within the Department of Health, what is happening in the districts and the sub-districts, right? So it is not just going to happen. The other issue, that is also quite important is because, we've kind of said here, in as much as we don't have an authority to make decisions, the authority to make decisions, but we have, for instance, said at primary PhD level, right? Ideally, we don't want to have dentists there, right? We need to have oral hygienists and dental therapists. Part of what they need to be doing is to be doing education and health promotion activities, right? That will go a very long way in taking care of, the burden of disease that arises because of the absence of education and prevention at that particular level, right? We have said that, the issue that I raised about the upskilling of dentists and also dental therapists, by the way, there was a method to the point where the reason why I raised it, because there will never be enough periodontists in South Africa, whether in the private sector or in the public sector, let alone in the public sector, let alone in a rural district. Now the point is, what is preventing us from skilling the dentists adequately to be able to manage periodontal diseases, right? For me, it makes perfect sense. It actually, right? But you cannot, for instance, expect a dentist to be doing 96 extractions, followed by, 10 perio root planings and so on. It is simply not possible, right? But it is definitely possible to train dentists at the right level of care to be able to manage periodontal cases. You probably, 98% of the time, you don't even need a periodontist to be able to do that. Dentists can adequately do those things. Dr. Poswa has said, for instance, that the master's program in interceptive orthodontics is starting to bear fruit, right? And the burden of malocclusion in rural South Africa is incredible, right? But why is it not possible to get more dentists to do the master's program in orthodontics, in interceptive orthodontics, right? Because they are exactly where the patients are, right? They will be able to manage those particular cases. So a case has to be made for dentists, for universities, and policymakers generally, to look at, what is it, within what we have, the solution is going to come, by focusing on what is already there, right? And all the things that I'm talking about are there. The solutions are going to come from doing the things that are there, improve on them, right? And we can go so much further. Issues of attitude. What Dr. Mtetwa has talked about, leadership, right? Because my sense, and that's the sense that I get from other people, is that there's a certain culture of non-performance in certain facilities that is taking place. Now you find dental assistants. They could have been in the system for a very long time. They came in during a particular point in time where the culture was we do extractions in the morning from 10. From after lunch we start sterilizing instruments, right? After 2 o'clock, there's no service, right? So, but it's a culture that has developed over a long period of time. Now we find ourselves in a situation whereby you get a young lady, 23, 24 years old, probably is the most senior person in that facility. That lady stands no chance against the culture that is already existing there. So, right, but we have to look into those issues. How do we change, that culture? Dr. Mtatwa said at a certain point that at some point we have to accept the historical issues, but draw a line so that we need to move forward, right? So those are some of the things that can possibly happen. So the aim of this discussions today was not so much to come up with the solutions, but to start a conversation, right? The Dental Professional Association is an association of dentists, and dentistry is what has been gifted to us, to change the world. This is what we need to do. The majority of our people in South Africa access dental services via the public health sector, right? And as the DPA, we are certainly convinced that the biggest contribution we can make in dentistry is really to improve the state of oral health services in the public sector and also in the private sector, because a lot of our members are also working in the private sector. But equally important is we will make the biggest impact by changing the status quo as it exists now in the public sector. And we are not being judgmental. We are not saying that everything is bad. Clearly, from today's discussion, I'm actually convinced that there's a whole lot of good that is happening in the public sector. There's still a lot that can still be done, but I'm convinced that colleagues are hard at work, doing the best that they can. Challenges notwithstanding, right? So this is the start. It's a little bit late in the year. Everything that took place here today is recorded. We're going to sit down, and we should have more of these type of discussions, all right? The most senior person in oral health in the country is here today. Dr. Poswa is very senior in her position in Gauteng. We've got Dr. Ndwandwe, she's holding a very strategic position at this particular hospital. We've got Dr. Mtetwa, who's our ally. He'll always be, right? So there's a lot that we can do. We just have to understand that it is our agency to lead in this space. It is our agency to make changes in this particular space, right? So definitely, as the DPA, we want to see more of these engagements, but move beyond just talking and start influencing the decisions, with the at the right places, and hopefully in time the situation will start changing, right? So colleagues, thank you so much. Thank you very much, Dr. Mtetwa, Dr. Ramdao, Dr. Poswa, for a marathon session, and also to you, Dr. Mkuba. Those who will be traveling, I wish you a safe journey back. I know there are people from Rustenburg. I saw some people from Rustenburg here. So I think it was a success, and we should definitely have more. Definitely earlier in the year, we should have something like this again, and many more to come. All right? Thank you so much for your attention. Thank you.
And a big thank you to the Pixley Dental team from me to you guys. Thank you.